Boleh lah tu kan? Ramai kan? Boleh. Dr. Virus ada? Dr. Virus tak boleh full score. Tak apa, never mind. Dr. Virus full score tak apalah. Kesian kat dia. Dia tak start.
Okay. A very good morning to Dr. Fairuz, Dr. Mashitah and my fellow friends. So I'm Tacha here. Today I'll be presenting on snake envenomation supervised by Dr. Mashitah. So envenomation due to snake bite is a well-known cause of morbidity and mortality worldwide. However, snake bite is a preventable public health hazard. Each continent and region faces its own unique species of snakes and corresponding envenomation syndrome. So let's go into today's topic. Snake envenomation. I'll be talking about epidemiology, classification of snakes, family of venomous snakes, clinical assessment, management, antivenom, and also complications. So first we look into the epidemiology. So this table is showing the data from the Health Informatics Center, the number of snake bite cases by state from 2010 to 2014. So if you look at the left-hand corner, it's showing the states. On top is showing the year 2010 to 2014, and the number showing the snake bite cases. So snake bite envenomation has not been formally made a notifiable disease in the country. Nonetheless, the overall number of snake bites in the country is available from the Malaysian Health Informatics Center. So if you look at the 2010 up to 2014, total of 15,798 snake bite cases had been reported in the country. And the number of deaths over the same period, total 16, averaging 3 to 4 deaths per year. And if you look at the states, the highest number of snake bites cases were from Kedah, 849 in 2010, and also Perak, 588. So Kedah and Perak, the highest number of snake bite cases, presumably associated with agricultural activities. However, unfortunately, the data showing number of cases that did not present to healthcare facility is not available. And this is the latest number of cases that I could find, the latest until 2014. So next we go into the classification of snakes. We can divide them into venomous and non-venomous. So under non-venomous, we have a Colubridae, the most non-venomous snake, for example, grass snakes. And under venomous is further divided into 3 families: Elapidae, Viperidae, Hydrophidae. Under Elapidae, the example would be cobra, crate, coral snake. Under Viperidae is pit viper, rattlesnake. Under Hydrophidae is sea snakes. So Elapidae is neurotoxic, Viperidae envenomation will cause hematotoxic, and Hydrophidae envenomation will cause myotoxic. So if you look at the difference between the venomous snake and the non-venomous snake, if you look at the picture on the left side, the venomous snake will have triangle-shaped head, they will have elliptical pupil, have heat-sensing pit, and they will have retractable fang. The fangs will be hidden under their upper jaw. Only when they are going to bite the person, the fang will be erected. And for the anal plate, they will have single row of subcaudal plates. On the other hand, for the non-venomous snakes, they will have rounded head, round pupil, they won't have heat-sensing pit, and they won't have fangs. And for the anal plate, they will have double row of subcaudal plates. And if you look at the type of bite, it will look different. This is for the venomous snake, and this is for the non-venomous snake. So, the snake of medical importance in Malaysia. There are more than 140 species of land snakes found in Malaysia, and only about 17 of these are poisonous. The important venomous snakes in Malaysia are the cobras, vipers, and the kraits. And these are potentially dangerous local snakes. The Malayan pit viper, the cobra, the shore pit viper, banded krait, Malayan krait, king cobra, and also the coral banded snakes. So let's look into the family of venomous snakes. So first I'm going to talk about Elapidae. So they are relatively long and thin. They have large, smooth, symmetrical scales on the top of the head, if you look at the picture. And they have short, permanently erect fangs. If you look at it, it's permanently erect, it's fixed. And then some, notably cobras, they raise the front part of their body off the ground and spread and flatten the neck to form a hood. If you look at the picture, that's how they will be before biting you. And one cobra, Naja sumatrana, they can spray its venom for 1 meter or more towards the eye of the perceived enemies. So these are some of the examples of Elapidae: banded crate, red-headed crate, blue Malayan coral snake, speckled coral snake, monocled cobra, king cobra. So what happens when you get Elapid envenomation? Elapid venoms generally exhibit neurotoxicity. The earliest symptom of systemic poisoning is a feeling of drowsiness and vomiting. The typical symptoms happens within 30 minutes to 6 hours in cobra bite and 6 to 24 hours in crate bite. So these are the symptoms in chronological order. So first, patient will present with ptosis. They will complain saying they have heavy eyelid. They have difficulty opening the eyes. Then they will complain of diplopia, double vision. Then they will have dysarthria, dysphonia, difficulty speaking. And then they have dyspnea, difficulty breathing. And at the end, they will have difficulty swallowing, dysphagia. And finally, they will have paralysis of intercostal and skeletal muscle occurring in descending order. So the breathing will become increasingly difficult, and in severe poisoning, the respiratory failure will set in rapidly. This is the neurotoxicity. If you look at, they also can cause local effect like pain at bite site, local edema, pain at regional lymph node, local skin discoloration, and also necrosis. So to be easier, you can remember 5D and 2Ps. So the 5Ds will be diplopia, dysarthria, dysphonia, dyspnea, dysphagia, and 2Ps will be ptosis and paralysis. So these are the neurotoxicity effect. So in Elapid venom poisoning, so the symptom usually patient will have blurred vision, circumoral gum paresthesia, hypersalivation, drowsiness. In the sign, you can look at, as I said earlier, the 5Ds and 2Ps. They will have ptosis, paralysis of the upward gaze, ophthalmoplegia, they unable to open the mouth, they will have protruding tongue, difficulty speaking and swallowing, and at the end they will have muscle paralysis. So this is a picture of a patient with ptosis due to a snake bite. So next family would be Viperidae. They have two subfamilies, Viperinae and also Crotalinae. They have long fangs which are normally folded against the upper jaw and are erected during a bite. Not like Elapidae, they have permanently erect fangs. In Viperidae, they have retractable fangs. The Crotalinae have a special sense organ, the loreal pit organ, to detect their warm-blooded prey. And the toxicology of venoms from Crotalinae snakes is significantly different from that of venoms from the Viperinae snakes. So these are the examples of the Viperidae: Malayan pit viper, Kyoman pit viper, Kinabalu pit viper. So the envenomation, Viperidae envenomation can cause hematotoxic effect. So, but in this case, the local effects will be more prominent. First, they will have pain and swelling. They will have local bleeding. They will have bruising. They can have tender lymph node enlargement. They can have blistering, local infection and abscess formation, and they can have necrosis. The local effects will be more prominent in Viperidae envenomation. And then they can have hematotoxic effect. For example, they can have hemoptysis, hemorrhage under skin and mucus, hepitaxis, bleeding gums, hematuria, and they can have internal hemorrhage as well. Patient will present with abdominal pain because they are having GI or retroperitoneal bleeding. They will have vomiting, and they also will be in shock due to this internal hemorrhage. They can have renal dysfunction and also cardiotoxicity. They will have ECG changes such as sinus bradycardia. So next family would be Hydrophidae. Hydrophidae, venomous sea snakes have flattened paddle-like tails and tiny fangs. If you look at the picture, the snakes having very tiny fangs. And the venom causes respiratory failure, a little bit of neurotoxic effect, myonecrosis, myoglobinemia, and also acute renal failure. So these are some of the examples. Banded sea snake, Hardwick sea snakes. So Hydrophidae envenomation will cause myotoxic. So the local effect will be they will be having little pain but no edema at bite site. This usually occurs during diving or sorting fish net, and their myotoxic effect will present as generalized muscle aches and pain. They will have stiffness and myoglobinuria usually after 3 to 6 hours after bite, and they will have hyperkalemia and renal dysfunction, which may lead to cardiac arrest later on. Non-venomous snakes, they have no grooved or hollow teeth. They have no specialized venom glands, no venom storage lumens, or any kind of anatomical venom delivery apparatus. So this is the table showing whatever I said earlier in a table form, which snake will cause which effect. And this is the predominant symptom manifestation. Local effect will be like local necrosis, ecchymosis, blister, swelling, compartment syndrome. Elapid will cause neurotoxicity, ptosis, diplopia, dysarthria, dysphonia, dyspnea, dysphagia. Viperic will cause hematotoxic effect, bleeding, dialysis shock, acute kidney injury. And Hydrophidae will cause myotoxic, muscle ache, muscle swelling, intravoluntary muscle contraction. So now we look into the management of the snake bite. So this is a flow chart. First, once someone is got bitten by a snake, first aid treatment must be given. Then the patient must be sent to hospital as soon as possible. In the hospital, a rapid clinical assessment and resuscitation must be done, followed by detailed clinical assessment and species diagnosis. Then investigation, antivenom treatment if indicated, and then you look for the observation of the response, and then treatment of the bitten part and treatment of the life-threatening complication. So the aim of the management will be to retard the absorption of venom, provide basic life support, and prevent further complications. So first aid treatment can be performed by the bystander or by the snakebite victim himself. If you are the bystander, you can reassure the victim, who may be very anxious. Avoid any interference with the bite wound, as this may introduce infection, can increase the absorption of the venom and increase the local bleeding. And you need to immobilize the bitten limb with a splint or sling before sending the patient to hospital. So these are some of the do's and don'ts. So what are the do's? You got to calm down, reduce movement, immobilize the affected limb, bring the patient to the nearest hospital as soon as possible. What are the don'ts? Take the patient to the shaman or snake charmer, suck the wound, cut the wound, tie ligatures, massage the wound, apply ice or electric shock, burn the wound, or apply any herbal remedies. So once the patient reaches the hospital, we need to clinically assess the patient. So first, we need to obtain targeted history. Okay, so some of the important questions that we need to ask. First, ask when, date and time of the bite. So precise time of the incident to monitor the progression of the signs and symptoms. Without knowing the date and time of the bite, we cannot look at the progression of the symptoms. And then you can ask for where, geolocation of the incident. Knowledge on geolocation of Malaysian indigenous snake in the region may give clue to the possible of snake species involved, and you can use most appropriate antivenom if indicated. Next, you can ask how did it happen? What the patient was doing before the bite? Was the snake situated on the ground or floor or on the tree? Any particular behavior of the snake? Was the snake hooting or spitting? Number of bites or strikes and duration of the bite. And then what happened to the snake after the bite? did the snake escape or captured or got killed. And then you can ask the description of the snake and picture of the snake itself if available. Then you can ask where part of body bitten. Next, what was done to the bitten area, any manipulation, any treatment given, tourniquet applied or not. And then last, you can ask if the patient has allergies or histories of anaphylaxis or any history of snakebite or antivenom previously. So following history, we can do examination. So the goal for the primary assessment is to identify any life-threatening condition, and resuscitation must be initiated immediately upon recognition. First, you need to look at airway. Is the airway pattern? Breathing. Is the breathing effort poor? Patient is bradypnea. Look at circulation. Look for evidence of shock or bleeding. D for disability. Look for the conscious level. Is the muscle weakness. E for exposure and environmental control. Look at the wound and control bleeding as necessary. Then you can go into general examination, take the patient's vital sign, BP, pulse rate, respiratory rate, SpO2, pain score and temperature. And then you can go further into the bite site examination. Look for the puncture wound, although these are not always evident. Look for the teeth marks, swelling, bruising, early sign of dermonecrosis, blistering. And then you need to palpate for the distal pulses, because in case of reduced or absent pulses, indicates patient it's going into compartment syndrome. And then you need to initiate RPP measurement, rate of proximal progression. You can use removable small microfold tape for labeling. And then you have to remove all rings, watches, any constrictive clothing in case of swelling. And then you also have to look for the draining lymph node, palpate for tenderness or enlargement. And then you look for systemic signs, such as I said earlier, the neurotoxicity, hematotoxicity, myotoxicity. The general non-specific features will be, early non-specific features will be nausea and vomiting. Okay, you've already taken the history, you've already done the examination. Next would be investigation. So you take the blood of the patient and then you send for FBC, because you want to look for platelet count. Platelet count may be decreased in victims of envenoming by vipers, and serial FBC will reveal a drop of hemoglobin if there is a significant bleeding. You also send for RP because you want to look at serum creatinine to rule out renal failure. You also want to detect electrolyte imbalance in patient with repeated vomiting. And you also can detect hyperkalemia seen following extensive rhabdomyolysis in sea snakes bite. And you also can send for LFT, where you can look for mild hepatic dysfunction, where there's slight increases in serum enzyme after severe local muscle damage. We will send for cohort profile, and it should be repeated 6 hourly for pig viper cases. We also send for CK for early detection of rhabdomyolysis, and serial test is done to monitor the trend. You can do urine analysis to assess for myoglobinuria, hematuria and proteinuria. ECG should be done to detect any arrhythmia, and ABG can be done to monitor and assess respiratory function. However, you need to be cautious because it's contraindicated in patient with suspected coagulopathy. So, what is 20-minute whole blood clotting test? It's a quick bedside test for an unidentified bite. You need to place 2 cc of freshly sampled venous blood in a small dry glass test tube. Leave it undisturbed for 20 minutes, and then after 20 minutes you just tip the tube, and if the blood has not clotted, that means the patient is having coagulopathy. Okay, so next would be monitoring, serial clinical assessment. Why do we need serial clinical assessment? Because it's more informative to guide the management. So we need to, if you look at these pictures, the patient unidentified snake bite, you will look at the wound progression. This is 4 hours, day 2, day 5, day 9. The wound progression shows typical dermonecrosis due to cytotoxic venom components that are present in venoms of some species. And on the other side, it's showing the progression as well, progression of local tissue injury following a Malayan pit viper envenoming. This patient has already completed 3 vials of antivenom, but you still look at the progression. Okay, so serial assessment of the patient's clinical progression should be performed for the first 48 hours of presentation and charted into the snakebite chart. So if you look at this picture, swelling progresses proximally after the left thumb was bitten by king cobra. So every hour you use the micropore to label and look at the progression. How far is the swelling spreading? Is the swelling progressing? That's the indication for antivenom. Then this is the chart. So every hour you check the patient's DCS, vital sign, BP, pulse rate, respiratory rate, SpO2, and you also have to look at PSP and RPP. PSP is pain score progression. Is the pain score reducing or increasing? And also RPP is rate of proximal progression of swelling. So for every hour, how many centimeter has the swelling progressed? And also look for tender lymph node. Not only clinically we need to assess patients serially, also we need to send serial lab investigation. It's not same for all snake bites. For Elapid, usually we will send baseline and then creatinine kinase 6 hourly and FBC daily. For pit viper, which has hematotoxicity, we need to repeat FBC, coag and CK 6 hourly. For sea snake, you will need to do serial urine FMA because you want to look at myoglobinuria. If unidentified, you need to do FBC, coag, CK all 6 hourly, others all baseline enough. So you have taken history, you've examined the patients and the blood investigation. So how to manage the patient? First, we need to give supportive treatment, give adequate hydration, give analgesia for pain relief, but IM injection should be avoided in pit viper snake bite because there's a risk of hematoma formation because they have hematotoxicity. ATT must be given. Antibiotic should be considered in snake bite with local tissue necrosis or extensive tissue damage. Eye irrigation can be done if there is a venom exposure in the eye. And then respiratory support in patient who have respiratory failure. So antivenom treatment. What is antivenom? Antivenom is a immunoglobulin purified from the serum or plasma of a horse or sheep that has been immunized with the venom of one or more species of snake. So how antivenom is made? First, we will collect the snake venom, which will then be injected into a horse to produce antibodies. Then the antibodies will be extracted and purified, and then it will be used as antivenom. So these are some of the example of the antivenom pictures. So what are the indication for antivenom? When do we give antivenom? So these are 3 indication. You have to look at the progression of local injury. That's why you need to monitor the RTP. And then systemic manifestation and deranged lab investigation. So how to know the progression of local injury is indicated for the antivenom? The local swelling involving more than half of the bitten limb within 48 hours. Swelling after bites on the digit, for example, in the toes, especially fingers. And then there is rapid extension of the swelling beyond wrist or ankle within few hours of the bites. And then development of enlarged tender lymph node draining the bitten limb. So these are the progression of local injury that indicates antivenom. And next would be systemic manifestation. Neurotoxicity like ptosis, paralysis, requiring ventilation, and then hematostatic abnormalities like patient having spontaneous systemic bleeding, shock, arrhythmia, patient having acute renal failure, and then deranged lab investigation, thrombocytopenia, prolonged INR, hyperkalemia, myoglobinuria, and also rapidly raising CK. All these are indication for antivenom. So when do you need to give the antivenom? Antivenom should be given as soon as it indicates. Once you see all this is happening, when it's indicated, you should give the antivenom as soon as possible. And then criteria for repeating the initial dose of antivenom. When patient, if already completed the first dose of antivenom, but then patient is still having persistence or recurrence of blood incoagulability after 6 hours, which means you need to repeat the antivenom. Patient is having persistence or recurrence of bleeding after 12 hours, having deteriorating neurotoxic or cardiovascular sign after 12 hours, persistent or deteriorating of compartment syndrome after 6 hours. All these are criteria to repeat the antivenom. Next, the choice of antivenom. Monovalent antivenom is given if the species is known. If you already know this is cobra bite, this is crate bite, this is pit viper bite, then monovalent antivenom is given. So the vials will be for cobras 10 vials, the crates 10 vial, pit viper 3 vial. Polyvalent antivenom is given if the species is unknown. If you see neurotoxicity, you give 5 to 10 vial, 12 hourly, depend on clinical response. And if you see hematotoxicity, you give 3 vial, 6 hourly. So types and dosage of antivenom. So monovalent, this is for cobra on top, this is for king cobra. For cobra, usually for local envenoming, you give 5 to 10 vials. If systemic envenoming, give 10 vials. For king cobra, 10 vials of antivenom should be given. This is monovalent as well for Malayan pit viper and sea snake. Malayan pit viper, you give 3 to 5 vials, and for sea snake, if it's mild to moderate, give 1 to 3 vials. If severe, give 3 to 4 vials. And this is polyvalent, got neuropolyvalent and hematopolyvalent. If highly suspected cobra, then you give 5 to 10 vials for local envenoming and 10 vials for systemic envenoming. If you think it's king cobra, you can give 10 vials. If it is banded crate or Malayan crate, you can give 5 vials. And if you think it's hematotoxicity, you're suspecting pit viper, you can give 3 to 5 vials. So how to give antivenom? As you can see, it comes in a bottle like this, in a vial like this. So you need to reconstitute the antivenom with 10 milliliter of water for injection. You should not shake the bottle. You should just gently swirl to dissolve the freeze-dried powder, and then you further dilute the solution in a hypotonic crystalloid solution. For children, it's 5 to 10 cc per kg. For adult, it's 250 to 500 cc of normal saline. So after diluting the antivenom, you need to infuse slowly at the rate of 1 to 2 cc per minute for first 5 to 10 minutes. And then you look for signs of any allergic or anaphylactic reaction. So if there is a reaction reappear, you need to stop the administration of antivenom immediately. You need to give IM adrenaline, IV Piriton, IV hydrocortisone, and once the reaction resolves, we need to cautiously resume and complete the administration of the antivenom at very slower rate. If there is no reaction after the first 5 to 10 minutes, after the first test, and then you can complete you can increase the rate and then complete it in less than 1 hour. So how to see if the patient is responding to the antivenom? So these are the things you can look at. In generally, the patient will be less nauseous, they will have less headache, they will have less generalized aches and pain. The spontaneous systemic bleeding will stop within 15 to 30 minutes. The blood coagulability will be restored in 3 to 9 hours. In shock patient, usually the BP will increase within 30 to 60 minutes. In acute hemolysis and rhabdomyolysis, will cease within few hours and urine will return to its normal color. That's why I need to do serial urine FME. And renal function will be still required to be monitored for several days after. So these are the life-threatening complications that we should be aware of. First, compartment syndrome. Patient will have pain out of proportion, increased compartmental pressure, paresthesia, paralysis, and pulselessness. So in this case, if patient is having a compartment syndrome, fasciotomy should be done, and you need to correct coagulopathy before that. In neuropathy, patient should be intubated and ventilated for airway protection. And then coagulopathy, you can correct with antivenom. If severe, you can use FFP. If patient is having hypotension, Fluid resuscitation should be adequate, and central line should be inserted with caution, especially with patient with coagulopathy. For rhabdomyolysis patient, optimization of fluid status, and you need to avoid nephrotoxic drug. And in renal failure, you need to give adequate fluid repletion. So those are my references. Thank you.
Tu dah ayo. Mana nak tengok amalan tu? Hello, hi.
Hi, Data.
So I think is very good presentation lah. Thank you, THATCHIYANI.
Thank you, Data.
Very comprehensive. And actually you already highlight everything in the CPGs. And your presentation also very easy to understand. Okay. So congratulations. Thank you for the presentation. Cuma I nak recap lah a little bit regarding, even though you already highlighted everything, tapi I just want to actually to recap the important things regarding snake bite.
Okay.
So all know snake bite is not it's not a notifiable disease. That's why kita tak banyak so called this information regarding snake bite. Dia tak, bukan kita macam kita setengah disease macam dengue, benda tu semua tu notifiable kan.
Betul.
So you got of so called, you boleh tahu berapa banyak sebenarnya dekat Malaysia ni kan. So the severity itself, tapi kalau you tengok you punya from the chart from you show just now tu, it shows memang banyak lah. Especially dekat bahagian north region ni. Okay, as you all know pun Kedah is one of the state yang memang so called in terms of using the antivenom we are the highest in the state lah. Kita highest dalam Malaysia ni. And it reflects us sebab yang paling banyak sekali guna dekat Malaysia ni ialah Melampit Viper antivenom, you punya CRAV dekat Kedah. So it reflects Hospital Sultan Abdul Halim. So at least you all should orang kata apa, should have a very good knowledge in managing snake bite cases lah. Maksudnya lepas you pergi MO ni tak semestinya you all akan posted in Kedah kan, akan posted di luar. At least you should know how to manage a snake bite. At least kita punya Melampit Viper bite lah kan. Okay? So the most important thing is you should know you should be able to identify the snake, because identification is very important sebab you nak guna, it actually can help you in managing the patient, especially if patient required antivenom. Okay, I think yang lain ni semua you dah present. Lepas tu the most important thing another is you kena tahu buat RPP rate of proximal progression. You punya rate of proximal progression tu, especially kadang-kadang staff nurse kita pun tersalah. The rate of proximal progression when you measure tu, it's not the subsequent rate of RPP is not you measure from the site of the bite, bukan daripada fang mark tu It's actually from the side, the last tape yang you letak tu lah. Okay, so it goes by there kan. Kalau macam daripada pukul 9 kena dekat sini, pukul 10 swelling dekat sini sampai sini, pukul 11 swelling kat sini. So pukul 11 tu you measure, it's not from the fang mark side, it is from the latest yang progression swelling tu lah. Okay, and then it goes by there. Okay, so that is important. Another thing is your antivenom, we do have two, monovalent and polyvalent. The one yang kita simpan dekat kita punya fridge tu is all monovalent monovalent. So we do have CRAV or Melampit Viper, we do have NKAV, Naja cotia for all this cobra species, and then we do have this not all cobra species lah, if you able to identify the snake Naja cotia and the one with yang ada kepala O tu kan. And then we do have king cobra. All the polyvalent antivenom will be stored in our pharmacy. Kalau indicated, kita akan minta dari pharmacy lah. So all district hospital in Malaysia, in Kedah state, we do have all monovalent sahaja So if you after this you posted to dekat Kuala Nerang ke, kat Baling ke, semua yang ada hanya monovalent saja. So if you unable to identify the snake and indicated to give the antivenom, either patient got sign and symptoms of neurotoxic or hematotoxic, so you have to send over lah patient to tertiary. Setengah tu kita boleh hantar je. You boleh buat, kalau patient stable, you boleh hantar you punya pharmacy to take the polyvalent tu lah daripada hospital primary. But we HSAH, we do ask our cluster to send over the patient lah to continue antivenom treatment. Okay, so indication jelas systemic envenomation, no doubt you have to give the antivenom. The so-called this kalau bukan non-systemic kan, you tengok you punya local progression kan, the one your friend mentioned just now lah. And then the dosage is same pediatric age group dengan adult age group tu sama saja dia punya dosage cuma the diluent saja yang berbeza. You go by 5 to 10 ml per kilo, you dilute dalam 5 to 10 ml per kilo. And then the dosage is accordingly to the CPG lah, macam CRAV tu kalau ikut CPG 4 vial ataupun 3 vial Okay, you punya Cobra, you punya Najah Kotia, kalau local you start dengan 5 vial. Kalau you ada systemic you start dengan 10 vial. Okay, kita start kat sini 5 vial saja so you can start 5 vial tu, lagi 5 vial you boleh ambil dekat farmasi. Okay, you punya flow stock. Okay, so others is yang regarding the so-called you punya symptomatic supportive measure, supportive treatment tu kan, you punya ATT should be given, but you should be cautious lah when because ATT bagi IM injection kan, especially in patient with Malaysian pit viper pit viper actually boleh postpone sikit dia punya ATT tu IM injection, especially kalau patient dah datang lambat, patient can develop systemic, ada coagulopathy. So actually you can actually postpone bagi IM, bukanlah postpone, tunggu sekejap lah, so you can monitor the blood, the coagulation profile dah balik sekali 2 kali kan normal, so you can administer ATT. Okay, you punya antibiotics as you mentioned lah, should be considered. Kalau prophylactic, there's no prophylactic of given antibiotic, ataupun you dah nampak memang ada necrosis, okay, so you can give antibiotic. Broad spectrum boleh start dengan augmentin. Okay, so lagi you punya analgesia, so if mild pain you can give PCM, paracetamol every 4 to 6 hours. And then aspirin and NSAID is not should be avoided. Okay, in patient who are at risk to develop coagulopathy, especially kalau ada Malaysian pit viper bite lah. Okay. Okay, so kalau moderate to severe pain, you boleh bagilah opiates. You boleh morphine. Boleh bagi teramal kan at the initial presentation. Okay. So steroid and antihistamine tak payah bagi. Okay, steroid and antihistamine. Setengah tu kalau macam AK tu dia macam spinal reflex. Semua bite dia bagi dengan dia bagi hydrocort, dia bagi piriton. It's not the prophylactic unless patient develop anaphylaxis allergic. That one pun jarang allergic to the bite itself. Most of the time allergic to secondary to you punya antivenom je lah. Okay, so yang tu je lah kot. Okay, so thank you so much for the presentation. Kita sambung dengan Jelly. Any question? Nak tanya apa-apa tak?
Tak ada betul.